Welcome everyone to week 4 of SPAAM seminars for this term. Our first speaker today will be our incredible events coordinator, Nathan, who'll be talking about using temporal constraints on healthcare capacity for optimal pandemic control. Take it away, Nathan.
Thanks. So for context, COVID was the first time that people doing optimal control had to consider the concept of having a wider healthcare system that might be overwhelmed. So typically they had some constraint in their cost function for preserving healthcare capacity. I'm going to talk about how they did that, and we're going to talk about alternative methods. So for context, this was the critical care occupancy, so ICU beds, over the course of the pandemic from the second lockdown. So this area in orange is the COVID patients in ICU. So this is, you can see with the third lockdown, there's this massive surge in healthcare demand. And then the grey region is basically free beds. So this figure on the surface level kind of demonstrates or tries to show that the healthcare system is not overwhelmed, with the caveat that this isn't an indication across England or any particular region. So a lot of people kind of post-pandemic talking about lessons we can learn is about these kind of legacy costs. So this figure obviously doesn't take into account what was happening in local hospitals, which often were overwhelmed, particularly in the first lockdown. The health of healthcare staff, so staff getting sick themselves with COVID, they were higher risk. Increase the number of patients per staff. You've got increase of ICU transfers, which is generally not standard practice. And then the use of ad hoc mechanical ventilators for kind of anesthesia, but not really suited to treating a respiratory pathogen. So all of these effects worsen patient outcomes in general. So having beds as a proxy for our healthcare capacity isn't generally the best practice. So what did optimal control people do? So we have some constraint in our objective function. I'm going to refer to this as a hard constraint, that the maximum ICU prevalence can't exceed some capacity, and they're using beds as a proxy. So the solutions coming out of these models, when you assume the cost of control is expensive, is that you kind of do nothing. You have a flat line where you bring up the reproduction number to 1, very close to your capacity line, and then you relax when you get to herd immunity. These strategies aren't really policy friendly. They're obviously not robust to any kind of uncertainty around what our ICU constraint is. So for example, there was a group in Imperial doing really important modeling for COVID. They estimated we had about 5,000 beds across Great Britain and the UK. And then this was later revised down to about 2,600 retrospectively. So this interpretation of a constraint is really a budget. So there's no kind of penalty for kind of just coming up, but not exceeding it. So it's not really good. It's not really policy friendly at kind of reflecting kind of this abuse of having like very long sustained periods of time where we're very close to saturation. So the goal of this is to have kind of an alternative constraint. So I'm going to refer to it as a softer constraint, which will kind of obey kind of these strain effects that we want to observe. So I'm going to use a very tractable epidemiological model just to demonstrate where some of the prior solutions I was showing on the previous slide, which are colloquially known as running hot strategies, are unfavorable under a soft constraint framework. They're not robust to any kind of uncertainties. And having some time-dependent strain effect in our constraint is important for making the strategies more policy friendly. So in our epidemiological model, new symptomatic cases are going to occur with this equation. So this RT here is the instantaneous reproduction number. So if I'm infected at time t, how many people would I expect to infect at future times? And then this W is the serial interval. So if I infect Ceteris, this is the time between me displaying symptoms and Ceteris displaying symptoms. So this controls the time scale of the epidemic. So that describes transmission, but we need alternative distributions to translate changes in transmission to changes in ICU because people take time to move to ICU, controlled by this distribution here. And then they spend some time in ICU themselves, controlled by this distribution here. So to capture the total ICU beds occupied, we're going to have our disease patients in ICU, but we're also going to have some background non-disease patients. So what happened is generally ICU bed occupancy runs at about 80%, but during the lockdown, we had to cancel elective care. So this was drastically reduced to 40–50%. We do this because we're going to implement the constraints as a function of occupancy rates. So it's important to capture the wider number of people in our setting. So this is the cost function. It's going to measure the health burden of our epidemic. And we're going to be implementing the constraints through this alpha parameter. So this is going to be the daily cost per patient. When this is 1, our cost function is just the number of ICU admissions over time. And we have this kind of weighting here, which is linked to our time in ICU distribution. So if I go into ICU 2 days before it's overwhelmed, my cost is going to increase for future times. So that's just reflecting that. So we're going to modify this alpha parameter to reflect our constraints. So the hard constraint is essentially when we're below capacity, it's going to be some kind of standard cost, assuming normal care. But once we exceed, it's some elevated cost. And this is basically like a Heaviside-like behavior where nothing is changing below the capacity line, and then you just get this dramatic increase. And then the simplest way of doing a soft constraint approach is that we're just going to relax this Heaviside behavior using this kind of logistic-like function. So here, this is the occupancy rate, and we have some scaling parameter V. So the idea is you have your hard constraint here where people modeling before are just assuming that nothing is happening to your cost per patient until you get to this line, ICU beds are saturated, and you get a really high cost. And the soft constraint is basically just relaxing that. So decreasing V is going to smoothen out this curve. And we want to kind of reflect 3 different effects. So firstly, we obviously want to penalize when we get very close, but not exceeding our healthcare capacity. Just above the capacity line, there is still obviously there are patients in ICU, so there is still some ability to treat patients, albeit at a very diminished level. And then there is obviously some larger dependence on our daily cost per patient. So we're going to have a time-dependent constraint. So long periods of high strain are going to be penalized. So to demonstrate how this works in comparison to kind of traditional hard constraints, I'm going to just outline some scenarios. So this is 2 sets of 2 control strategies directly competing. So by control, this is implementing lockdowns or social distancing measures to demonstrate scenarios where like a soft constraint framework would be more favorable. So we've got some emerging COVID-like pandemic. It's an established pathogen, and we're considering implementing these interventions to preserve our healthcare system. So these interventions are just going to be mapped through these direct changes in RT, so the reproduction number transmission. And we'll just compute some strategy costs as a result, both directly and subject to some underlying uncertainty. So the first scenario, we have these 2 strategies which on paper look like they don't violate our constraint, but they're going to have different costs depending on whether we use a hard or soft constraint. So the early suppression strategy is we're acting early, we bring in our intervention, we get R below 1, but not drastically below 1. So it's enough to flatten the curve and reverse outbreak growth, but you have kind of a long effect for it to really get down to lower prevalence levels. But you're never really threatening the ICU barrier. The late suppression strategy assumes that there's this trade-off. So it's implemented a week later, but the control is a little bit more effective. So it might have, might be more targeted to more high risk groups, so on. So the effect is that because of the delay, it's obviously going to get much closer to your capacity line before the intervention kind of reduces the prevalence. So on paper, a policymaker would prefer something like this, which is a flatter action, albeit it does have a slightly greater final size. So when we go and compute the strategy costs, the hard constraint says what these two lines asymptote to, basically. So a higher V is the hard constraint. And because Orange has a higher final size, so higher number of total people in ICU, it's going to be more expensive, so above our late suppression strategy in purple. However, with the soft constraint, the optimal strategy switches. So this is demonstrating the first effect that we want to show. So because this is getting dangerously close to ICU, we want to implement some penalty term, and that's enough to get it to switch dramatically. So in the short term, policymakers are choosing to enact a lockdown or some intervention, but in the first, if you take the first lockdown as an example, we had some uncertainty regarding our actual number of beds. So we're going to just do kind of a simple sensitivity analysis where the number of available ICU beds is going to be normally distributed. So its central estimate is this line here, and we're just going to vary the degree of uncertainty around it. And then what happens is here we're computing the difference in expected costs between the two strategies. So above this line, the orange early suppression strategy is better. Below it, the late suppression strategy is better. So what we really want to show is that if we have more uncertainty in our hospital provision, then the earlier action, so the early action to get prevalence low, is more optimal. So then the second scenario is more directly informed by the current literature, where we had these optimal mitigation strategies. We're going very close to the ICU capacity line, and this is quite unsustainable in practice, and it wasn't really modeled for policy. So just to demonstrate how kind of poor these strategies are, we're going to have some pretty bad strategy as well that does actually exceed capacity. But we want to demonstrate that even this scenario could be more favorable than this scenario. So this green strategy, so this is the running hot strategy, like in the literature, you act to bring R at 1 just before you exceed capacity. You don't exceed capacity, it's safe according to the hard constraint, and then you relax. Then with this kind of mistimed suppression strategy, we're bringing in an intervention a little bit too late, but ultimately it's going to suppress any further outbreak growth. And on average, it's going to have a lower number of total ICU admissions. So when we go compute the costs under the two constraints, this under the hard constraint, so kind of very high V, this strategy is deemed to be worse because it violates the constraint. It takes in that huge kind of penalty for saturated ICU beds. But under the soft constraint, we're going to be penalizing this long period just under the capacity a lot more than this period just above capacity here. So you actually kind of get that this grows exponentially with time, or as you kind of reduce the soft constraint, and it's far worse when we treat this constraint as ramping up at about 80 to 90% capacity. So the challenge is in the long term, knowing how to calibrate this soft constraint severity. So when exactly does the actual cost per patient begin to ramp up? So we're going to demonstrate by kind of looking at some uncertainty on how you quantify the soft constraint and how that affects the two strategies. So if we assume this to be normally distributed, so it has some mean and some variance, as we increase the variance, we get these cost distributions here. So the uncertainty in our underlying variable V is going to lead to cost distributions to the two strategies. And what happens is that these are qualitatively different. So as uncertainty increases, this running hot strategy has a heavy tail distribution. So for kind of most parameters, it's kind of fine. But as you kind of decrease V, these having a probability of having a very high cost leads to this kind of heavy tail effect. Whereas the other one is a bit more independent of variance, where the distribution is quite flat, and that's because it spends very little time just above the ICU capacity, and not that much time just below it as well. So you can go further and compute the difference in the expected costs. And again, this is just highlighting that our running hot strategy in green, when it's optimal, it's usually not optimal by a whole amount. So it's very kind of light shaded green, whereas when the mistime suppression strategy, the blue one, is optimal, it tends to be far more optimal. And then going further, it's quite obvious from looking at these graphs here, but just to highlight, if we were evaluating our strategies based on a quantile in the distribution, we're going to see that the mistime suppression strategy in blue is far more optimal. So as we kind of increase the quantile in the distribution, the space for which our strategy becomes optimal increases. So a policymaker who is just looking at something like the expectation alone, let's say they kind of exist on this line, might think there isn't a huge difference, but they're obviously going to compare the heavy tail here. They're going to reject the running hot strategy. So yeah. So in summary, we've kind of reviewed some of this optimal control literature, looking at how they've treated constraints in the past for healthcare capacity, and we've argued that if you want to increase the relevance to policy for some of these studies, then you should think of alternative frameworks for implementing your constraint on healthcare capacity. So it shouldn't just be kind of when you exceed the ICU capacity line, but it should also be taken into account these kind of long-term strain effects on the system. So yeah, thank you.